All right, let's get right to it. To absolutely crush the neoplasm section on your boards, you have to nail the logic. This is your mission briefing. Let's begin.
The stakes could not be higher. For your exam, and way more importantly, for your future patients, you have to know this stuff cold. So, let's lock it in.
But first, you know the drill, the mandatory disclaimer. This is for educational purposes only, specifically for international medical exams. This is not medical advice. Always consult official guidelines and a specialist for any clinical decisions.
Okay, let's build our master flowchart. The very first decision, the first gate you have to pass through when you see a crazy high white cell count, is figuring out if you're dealing with something acute or something chronic. We'll call this the maturity red line.
So, you get a lab report. A patient's white count is 50,000. Does your heart start racing? Well, hold on a second. That number just tells you the factory is working overtime. It doesn't tell you what kind of product it's churning out. Is it a sudden, violent storm or a slow, steady expansion? And this is how you find out. Your first logic gate is the peripheral smear. You look at the cells. If that 50,000 is made up of blasts, you know, those big, immature cells with prominent nucleoli, maybe some of those needle-like hour rods, you are in an acute storm. And if a biopsy shows over 20% blasts, you've confirmed leukemia. But if the cells look mature, like normal neutrophils in CML, then it's a slow expansion. And remember this, you never treat a slow burn problem with a 5-alarm fire. Maturity is your first, most critical check.
Okay, so let's say the smear showed mature cells. We're in a chronic expansion. What's our next move? We have to find out what's driving this thing. We're hunting for the genetic shunt.
Now, for your boards, there are 2 super high-yield genetic markers that you just have to know. Think of these as diagnostic cheat codes.
And the connections here are direct. They are one-to-one. You see the BCR-ABL gene, you think chronic myeloid leukemia, CML, period. You see a JAK2 mutation, you should be thinking of a myeloproliferative disorder like polycythemia vera. That's what we call thick blood. Just weld those associations together in your mind.
Okay, we've covered blood, we've covered marrow, but what happens when the patient doesn't come in with a weird lab value, but with a lump, a hard, palpable lymph node they found in their neck? Well, now the rules of the game change completely.
And I absolutely cannot stress this enough. For your exam, if a question describes a hard, rubbery, suspicious lymph node, there is only one correct answer. It is an excisional biopsy. Not a fine needle aspirate, not a core biopsy. You take the whole thing out. Why? Because you need to see the architecture. This is a non-negotiable, always correct answer. Got it?
And why do you need that whole darn node? Because you're on a hunt. You're looking for these guys, Reed-Sternberg cells. These are large, malignant cells that have these 2 nuclei that make them look like owl's eyes. These are pathognomonic, which is just a fancy way of saying if you see them, you have your diagnosis. It's Hodgkin lymphoma. Game over.
Okay, everybody, lean in for this one. I mean it. We are about to disarm the single highest yield, most common trap on global medical boards. This is the multiple myeloma trap. Getting this wrong is a critical error.
Your suspicion for myeloma starts right here with the PLAB criteria. C for high calcium, R for renal failure, A for anemia, and B for bone pain or lytic lesions. You see this constellation of symptoms, maybe with a monoclonal M spike on protein electrophoresis? Your multiple myeloma alarm bells should be screaming.
And here is the trap. The patient has the CRB criteria, so you think, I need to look at the bones, and you order a bone scan. That is the classic wrong answer. And here's why you have to know this. The scan will come back falsely normal. Why? Because myeloma is a purely lytic disease. It just punches holes in bone. It only destroys. A technetium bone scan only lights up for blastic activity, bone building activity. Since there's no building going on, the scan is blind to the damage. The correct answer, the test you need to pick on your exam, is a skeletal survey, which is really just a series of plain X-rays, or an MRI.
Let me put this as bluntly as I can, and this is a quote you should burn into your brain. If you pick the bone scan, you will miss the killer. It's that serious. Don't fall for the trap.
All right, let's lock this all in. We're going to do a rapid-fire review to sear this entire logic loop into your brain for effortless recall on exam day. You ready?
Blasts over 20%, bam, that's acute leukemia. You see our rods? That's AML M3, and you better be thinking about starting ATR right away. The BCR-ABL gene? That's chronic myeloid leukemia, CML, no doubt.
You see Reed-Sternberg owl eyes, Hodgkin lymphoma, and you got that diagnosis with an excisional biopsy. And finally, an M spike plus holes in the bone. It is multiple myeloma, and you are not ordering the bone scan.
And just like that, the logic is sealed. You've just run the whole master loop. This framework will not only get you points, it'll give you the foundation for how to think about these diseases in the real world.
So you've mastered these slow-growing malignant clones, but what about when things go haywire fast? Are you ready to handle the sudden storms of the immune system or the lethal triggers of a transfusion reaction? We'll tackle that in the next briefing.